Time now for this week's Health Matters. Paul Critz here, along with PA Lynn Szabo. And Lynn, you've got afternoon plans. You're up the road here when we're finished for the walk-up clinic, correct?
Yeah, so glad it's not raining.
It's not raining, but it is. We were talking about the time. We have had the time change, so you will have the darkness.
Yeah, we're a little bit in the darkness.
Well, that's good. I'm glad you'll be just right up the road, taking care of the people what need taken care of, just like everybody, it seems, in our community. This week, I forget who it was. Somebody told me a story, and it was a frustrating story, or a story of frustration, rather, about trying to get a prescription filled and going back and forth with the pharmacy and the doctor's office, where and had it been phoned in, it hadn't been phoned in. They said it had been phoned in. Oh, it'll take 45 minutes and all of this stuff, and a lot of frustration voiced about the pharmacist, or at least the person behind the counter at the pharmacy, not necessarily the pharmacist,
right.
But and it just seems that's such an interface for folks here, healthcare wise, in Del Norte County, almost like we spend more time dealing with the people who hand us our medications as opposed to the people who prescribe us our medications. Is that a fair sort of assumption to make in a rural community?
Yeah, I would say that, but there's a player missing in your scenario.
What's
the
that?
People who pay for the medications.
Okay.
And
okay.
and then the number 4 is the pharmacist who owns the pharmacist or pharmacy and pharmacist probably, and what they're up to. And so I think a lot of the problems that I see are less about the people that the patient is faced with, so provider and pharmacist, and really more about the insurance company, pharmacy chain issue.
Okay. Is it that the person who's frustrated at standing there at the pharmacy, is it that oftentimes they're just feeling the downstream effects of those other relationships?
Right. And the story is more complicated than the provider. We don't call things in, so there's something wrong with that from the gate. I mean, we send them electronically.
Oh, okay.
And so there's
that may have been my just characterization of what it was.
Yeah, there's IT imperfections for sure. And then the pharmacist also has an incredibly hard job. And oftentimes we're yelling at the pharmacist for something that's completely beyond their control.
Right.
And they just don't go into it because they're kind of, I think, demoralized a little bit. And
is that different? Is that different for rural pharmacists as opposed to, say, urban pharmacists?
Yeah, totally. And it's because that the rural community and its lack of resources also lacks pharmacies. And so here, we haven't had an independently owned pharmacy since Pacific Drugs, I think.
Right.
There's 3 that I can think of in Humboldt County.
Still?
Yeah, Barnes, Lima's, and Clooney's.
That's so old-fashioned.
Yeah.
That's cool.
That's kind of cute. You can get the old-fashioned candy there, and they talk to you. They know your name. Wow. They remember you're allergic to penicillin, stuff like that. And they're people that have been working there for a long time and not a traveler. A lot of the chain pharmacies have travelers, but I digress. So we also have a problem, and it's been lately, that the number of hours that a pharmacy is open is now being limited, and we're going to feel this over the holidays. Limited,
but just for all those very same reasons, for cost.
Yeah, many of our pharmacies that we always relied on to be open on the weekends are now not open on the weekends. Yeah. Many of the pharmacies that we rely on to be open around Christmas time or Thanksgiving, not going to be open. It used to be the prevailing feeling in medicine was everybody did their time. Disease doesn't take a day off. Neither do we. It's our year to do Christmas.
Like they'd rotate, right?
They rotate and they'd step up to the plate. But chain pharmacies have kind of changed that because, the travelers who are not really committed to the community, they're not bad people, but they want to have Christmas with their families. Sure. And so they can't get anybody to work on those days. And that's a huge problem.
Do they even try? Is it like a corporate thing? I mean, it's not so much. I can't imagine like CVS is out there looking for pharmacists specifically to work on Christmas.
They can't even get a pharmacist to work on Monday.
Well, yeah, yeah, right.
And it's not CVS in particular, though. CVS is kind of highlighted in that problem right now, but it's all of them. If people get COVID, the entire pharmacy staff goes down, and then they're on quarantine. There's no real backup.
I guess with the implication to what you're describing is that it makes it seem like these corporate entities are sitting back. They really want to give us that same level of service that we get from mom and pop businesses and pharmacies. But they just can't get the people to do it.
No,
it's not as simple as that, right?
It is super not as simple as that. They really want to make money.
Yes.
And if they don't sell enough on the weekends or on Christmas,
then there's no reason to
pay somebody higher wages to work that day, then they're not as concerned about the kid with the ear infection.
That's it. That is the base equation.
Right. And also there's a huge push in the last, I would say, 2 months to change everybody over to mail-in pharmacies. Huge push.
Oh, my God.
Yeah. A lot of discussion about it. Like I said, intrusive pop-ups on the electronic medical records. And
trying to push you as a healthcare provider on the back end, on the under the hood interface that you have. You're getting pop-up ads
and the message
pushing
is
you to...
like, this patient's insurance wants you to use this mail-in pharmacy for this drug at this quantity. And I'm like...
That's not what this calls for.
I don't really want to kill the person.
Oh, my God.
Yeah.
That is just that's so dystopian to me. That always just like you have to fend with the pop. You have to, fend your way through the pop-up ads trying to steer your healthcare decisions in a specific direction based on cost.
It's like they're trying to take my license to use for their benefit. So yeah, it's a money game. It's a big money game. Wow. And part of the reason I've been wanting to talk about this is I notice on Facebook that there's a lot of, that pharmacy, that pharmacist and that pharmacy, and I'm seeing it also in Humboldt County. And that's not really what's going on, folks. And it's going to get worse. Mm-hmm. So.
Yeah, this isn't the pharmacist isn't going out of his or her way to piss you off. This is a systemic problem.
Yes. Yeah. And again, we're asking the question, is healthcare a right or a privilege?
Right.
And so right now it's a privilege. And it's a privilege not only of the insured, but of, what insurance you've got. Mm-hmm. But why is it going on? Well, besides money, about half of the drug plans, the reimbursement that they give the pharmacies for covering a prescription will actually cover the cost that it takes to dispense that prescription.
Okay.
So
they're just covering the cost of the drugs and they're not covering the labor involved.
When the pharmacist is filling a prescription, and I know that electronic medical records kind of keeps it easier for people to look at financial data and to understand the reasons that things are happening. But oftentimes the pharmacists will not necessarily stock what isn't in their financial best interest.
Sure.
And that's not the pharmacist making a decision. I misspoke. So that's the chain making that decision. Mm-hmm. And so oftentimes you got a kid, like a little girl with a urinary tract infection. There are certain medications that are stupid to prescribe, but they're also very, very common. And I've seen little girls that ended up in the ICU in renal failure because they had overwhelming bacterial infection because they weren't put on the right drug.
Oh, wow.
And so, but the pharmacist doesn't really know what the right drug is. I mean, they're highly educated people, but I have the antibiogram specific to this area. And I know if I'm not really just rolling the dice, I'm making an up-to-the-minute, super educated decision about what drug I want and the dose that I want.
Right.
But they're saying, hey, we can't get it in till Thursday. And, and I'm talking about somebody I saw on Saturday who's sick then. Mm. And oftentimes they'll either say, look, your provider won't switch it to a more readily available drug.
Oh my God.
And that's not the rest of the story.
Yeah.
The rest of the story is don't want to kill a kid. So, trying to go for the best as opposed to what the pharmacy is going to make out of it. Mm-hmm. But So there's an increasing, there's a thing called pharmaceutical benefit managers. So this is an IT entity.
Before we forget and before we move on, I'm sorry, I want to come back to that very point, right? You said, what was it? You referred to it as the antibiogram or whatever. What is this?
Yeah, it's super cool.
What is that?
I love those. So they used to be put out in July by all the hospitals, and the medical technicians would look at all the organisms that came out of wounds, in the community, and what specifically, what drugs work well for those types of wounds, what the specific organism, what's killing it, what's not killing it. And Sutter used to put one out. Joe's used to put one out. If you asked him, Mad River used to put one out.
Wow.
So it used to happen spontaneously in July.
So you, as a healthcare provider, you get like, okay, well, then I should stock up on these particular meds because this is the kind of problem that we see here in this area.
Right.
That's cool.
So what we choose to prescribe in terms of antibiotics for infections is not like pulled out of the air. That's why your cousin's old amoxicillin isn't going to work necessarily. So very specifically chosen. And so Sutter stopped doing that. They must still have the data somewhere, but they stopped publishing it and making it available. And Mad River also stopped. I haven't asked at Joe's, so I don't know.
And what was it called again?
It's called an antibiogram.
Antibiogram.
But
That's
I
what
pay
thought.
I pay for a medical library. I pay about $200 a year, and so it's on my phone. And they recently put a site-specific antibiogram, which has this up-to-date information at my fingertips.
That's cool.
And so I put in the zip code, and they're like, "No, don't use that. Use this." But the pharmacists, not the pharmacists, but the pharmacies, the chain pharmacies, are not making antibiogram-driven decisions. They are making financial decisions.
Right.
And
this is why you can go to Walmart in the fall here and not be able to buy a raincoat because they're not stocked at that time at Walmarts, regardless of where you live.
Even though the rain is here.
Yeah,
totally.
Gotcha.
So there's another thing called pharmaceutical benefit managers, and this is like, I guess you could call it an app. This is an electronic tool in the electronic health record, and what it does is it tells the pharmacist what the most financially optimal drug is. Okay, and what the insurance is going to pay for.
This is like a tool, an application, something? Okay.
But it's not medically driven, it's financially driven.
Wow.
And it costs the pharmacies to access. It costs like 15 cents every time the pharmacist accesses it.
Wow.
So that's why there's a lot of times where the provider will make a prescription available and the pharmacist will call back and say, I have it in stock, but the insurance company, it's not their preferred. And so can you go with this drug? And I said, well, it's got a 75% resistance rate. So yeah, I could if I wanted to kill the person.
So...
And it's not only antibiotics, I should make that clear.
Sure, everything. But so for a PBM, who are they trying to save money?
For insurance companies and pharmacists.
And they're not
pharmacies.
It's one thing I can go, okay, well, yeah, here's this person sick with this. Here's a suggestion to save this person some money.
This has nothing to do with
That's not what it's about. It's about we're lowering costs on the back end.
It might be secondary because maybe there's a higher copay if you go with a drug that's not preferred.
Right.
Okay. Wow. I think that's super stinky. So it actually, and not only that, it costs pharmacies to access that database. So, and then what they do is they use this tool to do end of the year audits on pharmacies. I'm talking about chain pharmacies, well, probably any pharmacy, but here it's chain pharmacies. And they do a drawback of funds.
Okay. So how's all that work?
So that means they do an end of the year audit.
Yeah.
They know specifically what they're going for.
What are they going for?
It's like...
What are they looking for?
It's like they changed the rules. So they're looking for drugs that weren't the preferred drugs.
Times that people ignored the recommendations of the PBM.
Right.
Okay.
Right. And then they draw back money at the end of the year.
Saying what? You could have saved this much.
And it's random, and it's kind of like...
No.
like a plane falling out of the sky and hitting you. While
Stop. Drawback money. What's that mean?
That means that they actually take funds away from the pharmacy, and it goes back to the insurance.
So you get
company.
Penalized for not listening.
And it's random. I mean, not really random. We know it happens at the end of the year, but it's not like the rules are really clear. They're super vague. They're open to interpretation. It's a waste of time to argue with them. And
much like an IRS audit. Who's doing the auditing?
The insurance companies.
Wow. So they'll come. Okay. All right. So they'll come. Oh, man. Okay. All right. Who created the PBM? And is it something...
The insurance companies and probably electronic medical records people.
Are there specific PBMs for specific insurance companies?
Right. Mm-hmm. And they change day to day. So what was cool last Tuesday might not be cool this Friday.
Right. But it also, you would be accessing different PBMs depending on who came to the window, right? What insurance they had.
Right.
Gotcha. So
you have to have up-to-date information, but it costs you to get that information.
And so at the end of the year, some random insurance company can run an audit on how you interacted with their PBM and then take money back from you?
Right. And so it works really well. So 1 year, and I don't have the exact year, but an average for one of these change was $52,000 per $6 million of interactions.
Okay, you clarify those numbers. So I imagine $6 million worth of interactions. So, you're talking
so within that frame, so an interaction that big,
an interaction with whom? Between whom?
Between the insurance companies and the chain pharmacies.
Gotcha.
So they had a drawback of $52,000. And then the next year, it went up to $225,000 for the same $6 million. So it's a set of $6 million.
Okay. So yeah, $6 million
defines the set.
That's the set, and that's $6 million worth of interactions between.
And it works so well
between pharmacist and insurance company.
And it works so well, they got super aggressive the next year.
Okay, so hold on. So at the end of the year, then you're saying that their drawbacks amounted to $52,000 initially of that $6 million worth of interactions. Right. Next year, because they went, oh, hey, this is a pretty sweet deal. Right. Next year, it was $225,000 per $6 million. Okay.
So it's going up.
How are they? I mean, I guess you sign papers and that's what makes all this happen. But how in the world is anybody if somebody...
Right.
You want your money back? No.
So if you're an independent pharmacy like Barnes or Lima's or
you can't afford to do it.
What was that?
That money's spent already.
The rules are vague. The rules are inconsistent, and it's not like it's you get to write a check to them. It's like they suck it out of your bank account.
So then, what else happens if you're a chain pharmacy? And I imagine it's the chain and not the franchisee. Who knows what? I don't even know if it's like Subway and McDonald's if you're a CVS or something or a pharmacy. So if you're a chain, you have the wherewithal to do something like, oh, you want $52,000 back from me? Sure. But if you're mom and pop pharmacist, you might not be able to do that at the end of the year.
No, so there's not even a real way to challenge it.
Wow.
It's a grab back.
Wow.
And it works really well, so it's working more.
And the pass back and forth between corporate entities just means that it squeezes out any independent operators at all.
And it's also, that's for the independents, but it's also to the point where it's affecting some chains. Okay? And so this is where the local angle is. Okay. So recently, Bimart closed in Brookings.
Okay.
That was a huge, big deal, and it made a kind of a nightmare for everybody who switched to... Most people actually had to switch to Freddie Myers because right at the same time that was happening, Rite Aid decreased its hours.
Oh, man. Okay.
So the decrease in hours in Rite Aid was hypothetically, I don't really know, I wasn't in on that meeting, but this is what's happened. This is what the reporting is that Bimart closed all of its pharmacies because it could no longer make it profitable to do pharmaceutical services for people. And Rite Aid had to decrease the amount of hours they were open for the same reason. So that affects us here. That's what happened at this Rite Aid, according to my sources, which is national news articles.
Okay.
So, what we hear as consumers is, oh, they all got COVID, or they're having a hard time hiring somebody. But really, that's not what's happening. It's way more insidious.
Right. I mean, I'm still blown away by this whole, the PBM thing and how, I mean, the kind of stresses that it would put. I'm imagining like how this played out with the Buy Mart and with a chain like this then, because what this forces you to do is to stock. I mean, it takes all control of your pharmacy away and gives it to the insurance company, forces you to stock and to use and to dispense only what the insurance company.
And we already know that they're taking steps to encourage mail order pharmacy use.
So the insurance companies are they trying to cut out pharmacies? Are they trying to destroy pharmacies then?
I think so.
So because then they wouldn't have to pay as much out?
Right. Wow. And anybody who's ever used a mail-in pharmacy, patients don't really like them. I've never used one. But what I see as a provider is the medications never come on time. They're never quite right. You know, maybe a dose off or, smaller number of pills or something like that. And there's no way you can have an acute sickness and get a response that you need in a certain period of time.
Right. I mean, I even know just at the window, you've got somebody who walk at the window at Walmart. There's somebody who will walk you through all the drug interactions and things you have to take care of. And
that's the other thing. That's a super good point. So then that this article at NPR made is where when you don't get the pharmacist's information about what this drug means or when you should take it, or can you take it with grapefruit juice or on an empty stomach. And so those people bring the prescriptions to their local pharmacists.
Say, I got this in the mail.
Who has to take time off in their day for a non-reimbursed situation, and out of the goodness of their heart,
do something human.
They have to take time and take the legal liability to try and interpret it.
Wow,
it's something they had nothing to do with, really.
Oh my God. I know we've had trouble getting Mike the pharmacist in here for the last couple of months since that first time he was on, and I know you've spoken to him a number of times to get him in here, and now I could just completely understand so much more about his
dedication
plight.
To the community,
everything about him and the work that he's doing and the stresses upon him.
Incredibly awesome.
Wow.
Incredibly. And then I go back into a little bit of his story here. And, he left the area initially because he couldn't find housing. He has, I wouldn't say a large number of kids, but he needed a larger than average
number of
house.
Kids. Yeah. It was a Brady Bunch scenario we're talking about.
I think it was hers and ours or something, but he needed 5 bedrooms. He couldn't find a house. He said from Gold Beach down to Humboldt County.
Wow.
And he couldn't find a house.
Wow.
Like not in a house in his, in
that
a
he
certain
could afford.
price
He just couldn't.
He just couldn't find it. And he was looking to buy and looking to rent. So he was, for a while, after his kids moved and his family moved to Las Vegas, he was actually doing a pharmacy job and sleeping in his car.
Man.
Okay. And that's not that uncommon.
Yeah.
So don't yell at the guy.
Yeah.
Okay.
Yeah.
Don't yell at the pharmacist. It's really not their fault. So same problem in Humboldt County. They can't even get some pharmacists to go into rural areas, even with enormous sign-on bonuses, like way beyond anything I've ever seen for physicians or surgeons or medical people. So,
and that's a problem just across the board with everything, whether you're recruiting for law enforcement or any job in the rural, and just luring people away from the big city lights.
Yeah.
Come live out here where there's nothing. Where you're the thing everybody else is going to call.
Yeah, exactly. And that you kind of have a community expectation that you're always going to go above and beyond.
That you're going to be the mom pop who were there for generations.
Right.
Yeah.
Absolutely.
Wow. Oh my God.
So what's the average Delton order to do? Well, here's what you all should expect.
Break something. No. I'm just getting really worked up about this.
This is really bad. And this is, I'm dipping my toe into the pool of pharmacy nightmares.
Just a little, right?
This is just a little.
So I'm sorry, you had to build up. What can we expect in Delton?
So pharmacies will probably continue to close on weekends and holidays. So making it harder to get medications that you actually need because of, the acuity of the medical situation, or that you just forgot. Okay. So you're going to have to be patient. And I don't know that people understand that what they expect for a certain level of availability is just not possible anymore. And there's no individual person that's local that I think you can blame.
No,
okay? I think it's a financial entity, out there somewhere. So here's a little bit of good news. There is a rumor, this is kind of hallway conversation, that Open Door will open its own pharmacy.
Ooh.
Kind of in the way that UIHS has a pharmacy.
I had no idea UIHS had a pharmacy.
It does. And it's super helpful. Not everybody, I don't really understand how they decide who can access it or not, but I know they let me. And so what happens is that I get, my provider sends in a prescription and it gets sent to, because I live in Del Norte and the pharmacy is located in Humboldt County, they drive it up here. And if I lived in Klamath, they would drop it off at Klamath. I lived in Smith River, they would drop it off at Smith River Clinic. But because I'm more Crescent City based, then they drop it off at Crescent City. So I can wander from my desk down the hall, pick up my script, have the information, printed page of information that I don't really need, but they're making it available to everybody and for an incredibly reasonable copay.
Wow.
So I don't have to wait in line, really. The downside is that I don't always, get medications like exactly when I need them.
Sure.
But it's not hard to think ahead.
Yeah.
It's hardly the end of the world.
Yeah.
So if you think like a week ahead, you're fine.
Well, so that's fine. That's nice for you.
But that's also my patients at UIHS. That's also, so if Open Door is doing something similar, that would be amazing. Think of how many Open Doors there are, how much buying power they have as a collective entity. And I imagine that they would do a similar situation where their pharmacy is going to be located. I don't know if they would put them in every clinic or just a centralized one in Humboldt County with a courier that comes back and forth.
Like with the UIHS.
Yeah.
Huh. Let's see. I'm looking at all your expectations you have listed here. Fewer pharmacies will make costs go up due to less competition. Yeah. That's a nice passive way to phrase that. The pharmacies will raise their prices because they can. That's a little truer, I think.
Yeah, that's true too. That's not so good. Expect
to wait longer. To get your prescription. Sure.
Yeah, but I don't think I would. If you call in sooner, my perception is that you can get things with less wait. So
if you call in sooner, what do you mean?
Okay, here's an example.
Okay.
Oftentimes people figure out they're running out of medicine on Sunday, and there's a huge onslaught at 5 minutes after 5 of prescriptions that must be refilled right then.
Okay.
And so half of the staff at 5 minutes after 5 is out of the clinic. Okay. They've worked hard. They've been efficient. They've gotten their work done. Their work day's over at 5. They don't get paid after 5. And now
and it's a Sunday.
No, I'm sorry. This is a Friday because you know somebody's going to be out of medicine on a Sunday.
Gotcha.
Don't do that.
Yeah.
Think about a week ahead. It's not that hard. Okay. And if you're going for a narcotic prescription, the word on the street is if you wait till the last minute on Friday, then we will fill it without thinking about it. That's not true.
Okay.
More than likely, it'll just wait till Monday. Okay, so don't do that. It's not that hard to do that.
See, now it seems like you're blaming like the victim here when you're talking about like the things that we have to do, the things that are on us. It seemed like we've been talking about the systemic issues with pharmacies and rural pharmacies and the pressures of capitalism and all of that, and then
really I don't see that. I see that as if you put a little bit of thought into it ahead of time, you can dodge some of this, but not all of it.
Yeah, I guess I'm still coming at it from like I'm disappointed about how much we have to do ourselves now, I guess, because I was raised with a different expectation.
I'm disappointed at how fractionated people are. I mean, because you're fighting significant battles like on all these levels, like to get an MRI for your knee, to make sure that your medication is phoned in at the right time, to get an appointment with your doctor. I mean, it's like struggles on every front, and it's the same thing. when I show up at 8:00 on Monday, it's kind of like we're off.
Yeah, and we're off. Yeah.
And to try and make it doable for people requires big hearts, people like Mike.
Yeah.
So, and that's not always sustainable. And it's another thing realistically that makes our area unattractive for new providers.
Well, and again, I think that's something that applies to every area across the country that is analogous to us in our situation.
When I was in the Castro in the late 80s, early 90s, 18th and Castro had a Walgreens there. It was a flagship pharmacy as far as new interventions and stuff, and that it was open 24 hours a day, 7 days a week was like unheard of.
Wow.
And it had pill counting machines for like AZT and the other drugs that people with HIV needed, and it was phenomenally in tune with the needs of the community. So that was an example. I know they can do it.
Yeah,
I have seen it. So I think it would be super awesome if the mindset was different, but we go back to his healthcare right or privilege.
Right.
So.
Well, Lynn Szabo, thank you very much for this. I know we'll have more in future episodes to talk about just the plight of pharmacies and pharmacists in general. And if we can get Mike back in here at any time,
that would be great. I think he'd really add to these insights.
Yeah. Thank you very much for this week's Health Matters, Lynn. And we'll see you next week.
All right. Thanks. Bye.